Thank you, Dr. Umesh. Uh, my topic today is avoiding pitfalls and firefighting in IOLs. All of us would prefer to have our patient with a clear, distant, and near vision. This is what our goal was 15 years back. But this intermediate vision of late has become very, very important thanks to all these gadgets that we are using nowadays. Most of our reading is on gadgets, so intermediate vision is very important. Despite using the best of the lenses, this is what I've been found, almost 35% of the patients develop either photopic or the need for glasses after surgery. And when we classify in advanced IOLs, advanced I've used the word trifocal, it can apply to EDOF or anything. These are the commonest problem that a patient says: glare, halos, starburst, poor vision, poor contrast. Now, if you try to classify these into poor vision, which are because of refractive problems, and all others because of photic problems, and you look at the causes, the commonest causes in both, most of them are common causes, but these two, dry eye and PCO, remain common in both the segments, while a calculation of IOL power is predominantly causes refractive problem, rest of them. And look at that last one, unexplained. That's what science is. We are not able to explain everything. Now, again I said, despite this is probably one of the best lens what we consider, and despite using this best lens, look at this particular place and this place. Almost 15%, 13 to 15% needed glasses, they were not happy with the vision. This is with a trifocal, one of the very good companies. I'm not mentioning their name. All of us use these things. Now let's get into the quality of vision. It's not the typical glare, halos or something we get. Normally we get a combination like what we have in the lower part. So, if there is an increase in the refractive error, just like what you see, definitely the photic components are also increased. The first take-home point would be then target emmetropia. And how do we target emmetropia? Very good slide which was put up by Dr. Mohammad Shahbaz initially. Use proper formulas. The best of the formulas are the recent generation formulas, Barrett and Hill RBF. Now the question comes, I don't have an optical biometer. How do I use it? Very simple. It's available online free of cost. So utilize that. Only thing, use the ultrasonic, A constant or whatever factor that is for this. It's available free of cost. It's a large pool. It gets optimized every now and then. Next question. Simple thing. Very clearly it was elicited by my previous speaker, Dr. Subodh. Plano, you get very clear vision at all the three places. But look at just 0.5 cylinder. This is a simulation. What is happening? Vision gets affected. And this is very important in trifocals. I don't use the criteria 1. I use the criteria anything above 0.5 in these cases. This is not enough. Now, when you always use the toric calculator and look at this particular biometry. This is my TOMI optical biometry. Nothing wrong with the right side. I would prefer to use a toric IOL. Look at what's happening in the left side, which I have marked. Just shows 0.11. But when the astigmatism. But when the same thing is fed into a Barrett toric calculator, look at what's happening. It's asking me to use a T2. So, all cases, please use Barrett toric calculator, whether on your optical biometer or on the online, and then decide whether to use toric lenses or not. This is for advanced IOLs. I'm not talking about budgeted monofocal IOLs, if you're using advanced IOLs. The next thing that is done is always do 2 workups, 2 machines, 2 observers at 2 different settings and 2 different formulas. If I keep doing this, patient will metastasis in my nearest clinic next day. So, what I do is as soon as the patient comes, 2 formulas definitely we use, more than 2 formulas. On the day of when the patient comes to me deciding, I take a set of readings. As soon as the patient comes without putting any drops, and the second reading is taken on the day of surgery, most often 99% it matches. Very rarely there's a difference, which I explain to the patient, slightly delay the surgery, get the lens and get it done on the same day. Definitely I don't allow it other day. Problem with trifocals or any advanced thing is the rings, the dysphotopic effect. What do we do for that? pre-operatively counsel them, tell them that they are going to have these rings. And intraoperatively, very clearly shown by my previous speakers, look for that centration. Look for that centration. Make sure it's on the center of the lens what you place, and then complete the surgery. Post-operatively, the patient is going to complain about rings, no problem. What do I tell here? If you are seeing the rings, that means this lens is working. Also remember one more thing, when compared to multifocal rings what we were seeing, trifocals is very, very less nowadays. Multifocals, I have even explanted lenses. Trifocal, till now I have not explanted any lens for dysphotopic phenomena. Refractive error, yes, I have. Despite this, if the patient complains, this is the algorithm I use. If it is ametropia, either if the patient can manage with little bit of glasses, very good. Otherwise, either laser vision correction, or if it is a spirocylinder, rotate it, decentration, correct it. But if it is that intrinsic problem, if it is a PCO, we can correct it. Anything in the upper compartment, well. Keep on counseling about these rings. Invariably, it goes off, very clearly shown by my previous speaker. 3 to 6, 1 year, 3 months to 1 year is what we say. Maybe 6 months as an average. Most of these patients stop complaining. If they still keep complaining, what I do is I prescribe the costliest possible lubricating eye drops. Finished. Centration of the eye, sorry, I'm going in the reverse direction, sorry. Yeah. Post-op astigmatism, if it is a cylinder, if it is plain cylinder, nothing can be done. But remember, if it is a cross cylinder, say plus 0.5, minus 1, this is something that can be treated. Either way, enter your data on this, check whether it works, and then rotate the cylinder. If it doesn't work, yes, laser vision correction is possible. This is as a second option, we keep it. As I told you, photic complaints are very less with a trifocal IOL, more with a monofocal IOL, because that 16% of loss of light which causes this dysphotopic phenomenon is, most of it is used for intermediate vision, hence there is only 4 to 5% cause of photic phenomenon. Despite this, it can happen. And look at these three things. If you look at the aberration, spherical aberration and coma are the common causes. Where do we check? I have a pentacam, so you check in this area, the total spherical aberration. That's the most common one. And then the better one, of course, is the eye tracy. I don't have it. If people have, you can use it. Pre-operatively, if it is above 0.6, then I avoid surgeries. If the higher order aberrations above 0.6, avoid surgery. The next is angle kappa, which my previous speakers were talking about. Very easy to find on advanced machine. It just means that the visual axis is not corresponding to the where you have placed the center of the lens. That's what it means. If you don't have all these in advanced fancy equipments, you can still, here the cutoff limit is on my pentacam is 0.21. If it is IOL master you are using, I think it's 0.5. I don't have an IOL master because it calculates at different places. So whichever machine you are using, use the correct measurement for you. In pentacam, it's called chord mu, and it is available. Now, here comes a state we don't have the advanced machine. You simply have an auto refractor. That is enough. All of us know that the visual axis is always nasal to the other two axes. So for your normal patients, keep on looking at it. If it is large, avoid an advanced IOL. Now this is one of the studies I wanted to deliberately put it here. They wanted to learn about predictors of photic phenomenon after trifocal IOL, and finally concluded that there is no such thing. It is only the more you charge the patient, more the patient is unhappy. Again, if by chance the patient develops a problem, we can use cycloplegic, recenter the lens, intrinsic problems, treat it accordingly. Last few slides, please. Counsel again repeatedly if he has. This slide has already been spoken by Dr. Subodh Purohit. It's not just by one particular thing, IOL power, Q value, or whatever it is, whatever the happiness is, a sum total, needs neuroadaptation, wait for at least 6 months, and finally hit this patient with all the investigations. Sometimes we don't notice this. This happened 6 months after surgery. Macular edema, cystoid macular edema, to a trifocal patient who was 6'6", became 6'9", 6'12". She was actually complaining of contrast loss, which I didn't realize, and then with proper anti-VEGFs and steroids, they recovered. Finally, before you touch these patients, correct the dry eye. You don't have any advanced equipment, fair enough. Simple fluorescence is enough to classify these patients. Your autorefractor is enough to see the meibomian glands. Treat this patient as per this algorithm. This algorithm itself is a half-an-hour talk, so you can get this on ASCRS website. And final goal is to make your patients happy. Thank you once again for the opportunity.
Yeah, thank you, Ellen. I think preoperative counseling, postoperative counseling, or I would call postoperative reassurance more than counseling. It is preoperative counseling and postoperative reassurance to the patient, repeated reassurances. Thank you.